Super, thanks so much, talking on mute. I really appreciate the opportunity to talk with you today. So my name's Damon. I'm director of the Division of High Consequence Pathogens and Pathology at CDC, and I spent probably the first 15 years of my career at CDC in the laboratory and as a clinician, and helping in terms of some of the epidemiologic investigations for smallpox preparedness, and also did quite a bit of work on monkeypox, including work in the Democratic Republic of Congo. So it's a real pleasure to be here today. And if you want to go to the next slide, I'm going to give you an overview of monkeypox and the current situation as CDC and its partners work to prevent the spread of this disease in the United States and around the world. So what is monkeypox? So the disease is caused by monkeypox virus, which is an orthopox virus. It's a relative of smallpox, which is the disease caused by variola virus, but it has much milder symptoms in most cases. And historically, monkeypox was considered to be a rare disease and found in Western and Central Africa between the 1970s, and with episodic outbreaks and epidemics. And it was really discovered because of work to certify smallpox eradication in countries where disease was believed to have been eliminated, and cases that looked like the rash illness of smallpox were being identified. So monkeypox was discovered initially, not in humans, but in monkeys, in non-human primates, in outbreaks of pox-like disease, in colonies of monkeys, which have been kept for research and for also developing and providing the substrate to grow polio vaccine. And the first case of human monkeypox was recorded in 1970. During this outbreak in 2022, the number of monkeypox cases has climbed far beyond what has been seen in any other outbreak, with tens of thousands of cases globally and dozens of countries reporting them. So despite being named monkeypox, the source of the disease remains unknown. And people back in 1958 were trying to understand where the non-human primates or the monkeys had been infected, and it was very unclear. Experts have yet to clearly identify where the virus is found in nature, but it has been found in one squirrel in Africa and a monkey in Cote d'Ivoire. So the squirrel that was found infected in Africa was identified in DRC. It's suspected that African rodents and non-human primates may be involved in harboring the virus and then transmission to humans when they come and interact with the animals. In the past, monkeypox outbreaks were linked to direct exposure to infected animals or other infected humans and animal products as well. In general, limited person-to-person spread in countries has been documented, although increasing chains of transmission have been known to happen in the Democratic Republic of Congo and the Republic of Congo in the past few years. During the current monkeypox outbreak, the virus is being spread primarily through close, intimate personal contact, often of a sexual nature, between people, and male-to-male sexual activities, specifically things like anal receptive sex, appear to be drivers of transmission. Virus has been found in other studies in respiratory droplets at various stages of illness, and so we do ask people to take precautions as that as being a source of illness as well. So although anyone can get monkeypox through permucosal or break in the skin, most of those that are being affected so far during this current outbreak have been gay or bisexual individuals or other individuals who identify as being men who have sex with other men. WHO declared monkeypox a public health emergency of international concern at the emergency committee meeting in mid-July of 2022. And as of August, nearly 99% of the cases were reported from countries that historically are not known for having monkeypox outbreaks. In August, the US government also declared monkeypox a public health emergency, and the WHO replaced African regions in the names of the clades of virus. So we used to refer to West African clade and Congo Basin clade. We now refer to clade 2 and clade 1. And really that is because there are distinct genetic differences between the viruses in clade 1 and clade 2. There's different genes in those viruses, and there really do appear to be some differences in transmission dynamics and the disease presentation, which in general is more severe in clade 1 related infections than clade 2. And in this current outbreak globally, what we're really seeing is that most of the viruses are associated with what we'll call clade 2b. And if people remember the monkeypox outbreak in the United States in 2003, which was related to the importation of African rodents to the United States for the exotic pet trade, then transmission to prairie dogs in Midwestern America, and then infection of humans, those animals came from Ghana. Those rodents, and those viruses are more associated with what we'll call clade 2A. So next slide. So signs and symptoms of monkeypox. So globally, what we've seen with this virus, which we'll call clade 2b, the death rate has been far lower than historic cases in Africa, where in some outbreaks and with clade 1, up to 11% of unvaccinated individuals who got the disease died. The clade of virus in the 2022 outbreak has been associated with only a handful of deaths worldwide, fewer than 0.02% of reported cases. Some groups are likely at higher risk of severe illness, including children under 8, people who have weakened immune systems, such as those with HIV and AIDS-related symptoms, pregnant individuals, and individuals with a history of atopic dermatitis or eczema. We typically think of monkeypox starting with a flu-like illness, fever, headache, muscle aches, and exhaustion. Within 1 to 3 days, sometimes longer, a rash develops, often on the face, then spreading to other parts of the body. And that's largely based on work that was done in DRC in the 1980s, and really trying to understand this virus after smallpox had been eradicated, and trying to understand what the risk of the virus would be as a human pathogen. And recall, that's a clade 1 virus. Rash then progresses over a few days to weeks. Sores, blisters develop, then scabs, and eventually fall off. So what we call the macular, papular, vesicular, and pustular stages of illness prior to lesions scabbing. In this global outbreak, symptoms have varied from the historic progression. Rashes are common, but often starting in the genital or perianal areas. Sometimes fever is after rash onset, and sores may be inside the body, including the mouth, the vagina, or anus. Sometimes no rash appears on other parts of the body, and sometimes people get very generalized rashes. So next slide. So the first cases in the US were identified this year in May of 2022 associated with this outbreak, not long after the UK reported its first cases. Initially, most cases were connected to international travel, particularly to Europe. Now spread is mostly local within the United States. In mid-August, roughly 3 months after the first US cases of monkeypox were confirmed, the number of confirmed cases rose above 10,000. You can find a US map that shows confirmed cases by state and territory on our monkeypox website, along with other key data that get updated regularly. The link is at the bottom of the slide in case you want to visit it and use it. No deaths have yet been reported from monkeypox in the United States as of the 24th of August. So it's important to know that anyone can get monkeypox because it is spread through close skin-to-skin contact, often involving abrasions in the skin. And in this outbreak, however, the majority of cases have been in gay, bisexual, and other men who have sex with men. Cases in women and children have infrequently been reported. On the 10th of August, the Lancet reported a monkeypox infection in a dog that had close contact with 2 people with monkeypox. This is the first known human-to-animal transmission of monkeypox, and it is being followed up on to confirm whether the dog was actually infected. So, in the next slide. So case trends in the United States, what are we seeing? So you're looking at the number of cases on the y-axis and the cases reported by week on the x-axis in this graph. So in August, they broke 1,000 new cases a day being reported. For the most part, reported cases numbers in states have aligned with the sizes of their populations, and in general, more populous states have also reported more cases. This chart is also on our website and is updated regularly. The link again is at the bottom of the slide. New charts on the website add demographic data like sex at birth, ethnicity, and race. As of the 14th of August, 0.4% of monkeypox cases reported to the CDC were people of American Indian or Alaska Native descent. Information on race ethnicity was available for 47.5% of cases reported to CDC. So we're still catching up to learn more about the trends and the demographic trends. So next slide. Because orthopoxviruses are genetically very similar, U.S. smallpox preparedness work previously resulted in an FDA 510(k) cleared assay that labs are currently using to test for monkeypox virus. Lab testing capacity for monkeypox began in the Laboratory Response Network, also called the LRN. 5 large commercial lab companies have now joined in the testing, and U.S. labs can now test about 80,000 plus samples a week. Initially, labs sent all specimens that tested positive for orthopoxvirus to CDC for characterization, but the results of the characterization have consistently shown the circulating virus to be clade 2B of the monkeypox virus. As of August 2nd, Laboratory Response Network laboratories that conduct the CDC non-variola orthopoxvirus test are no longer required to send all positive specimens to CDC for monkeypox characterization testing. Laboratories only need to send about 10% of their positive specimens each month. CDC requests jurisdictions prioritize specimens to those if the patient is being treated with TPOXX, and that's designed to understand if any resistance to the drug is being seen, and specimens from persons with known recent international travel. So that's to try to understand if there's new variants being identified. Specimens from patients with unusual clinical presentation to try to see if there's changes in the virus or whether there's host factors that need to be considered. Specimens from pediatric, children, adolescents, and female patients, and unusual non-variola orthopoxvirus PCR results. A similar change for the commercial labs running the CDC non-variola orthopoxvirus test is planned for the near future. Because there are no other orthopoxviruses circulating in the continental United States, if a sample tests positive for orthopoxvirus at the state level, that means it is likely monkeypox. So this information is enough for healthcare providers and public health professionals to begin identifying those who may be at risk for disease. And so that usually initially involves understanding who may have had contact with those individuals. This can then help them determine who may benefit from vaccination. Treatments can be considered even before testing is done based on clinical decision-making between treating clinicians and public health experts. So in the next slide, we'll cover a little bit of vaccines, actually. Well, okay. So I'm going to quickly walk through some of the work on vaccines. So in certain circumstances, it may be recommended that people get vaccinated after confirmed or presumed close contact with someone who has monkeypox based on assessment of the person's risk for developing monkeypox. There's currently 2 licensed vaccines in the US to prevent smallpox, and one of which is also licensed to prevent monkeypox. And that vaccine is JYNNEOS, which is a 2-dose vaccine given 28 days apart, and ACAM2000 is a 1-dose vaccine. But ACAM2000 is a live virus vaccine, and so may be associated with a higher rate of adverse events, especially in those who are immunosuppressed or may be living with uncontrolled HIV disease. So JYNNEOS is initially approved by the FDA through a standard or subcutaneous injection, and now an alternative injection route, an intradermal injection, is authorized to be used under an emergency use authorization by the FDA. This allows the vaccine to be used more widely, and more doses can then be available for protection of those who are at risk. And I don't, unfortunately, I think the slide may be out of order, but there should be an image of how to appropriately give an intradermal injection. So antivirals, there are no treatments specific to monkeypox. There are some antivirals available to treat the disease. FDA allows the use of TPOXX, an FDA-approved antiviral to treat smallpox, and to treat monkeypox during an outbreak under an expanded access IND, which we're trying to streamline. Other drugs may be useful to treat against monkeypox, but have not been tested yet. We have vaccinia immune globulin, which is currently used with adverse events from the live replication competent vaccines such as ACAM2000. And it is also being made available for potential treatment of those with more severe manifestations of disease from monkeypox. Cidofovir and brincidofovir are very similar. Brincidofovir is the oral prodrug of cidofovir. Many of you may be familiar with cidofovir as salvage therapy for CMV retinitis. And it is a drug that can be given intravenously. It requires extensive pretreatment with fluid and with probenecid in order to prevent renal toxicity. Brincidofovir is the oral prodrug, so it can be given by mouth. It has a different side effect profile than that of cidofovir. And additional information is available on the CDC website. So what is CDC doing? I'll wait for the slides to catch up. What is CDC doing? Excellent. So CDC is working with the Indian Health Service, with tribal and state and local health officials to identify people who may have been in contact with people who tested positive, so that those individuals who are known as contacts who may have been exposed to monkeypox and may be at risk for disease can monitor their health and seek care if they develop symptoms. And if they're considered to be a high-risk exposure, and that criteria is also on the CDC website, post-exposure prophylaxis with the JYNNEOS vaccine can be offered. CDC has distributed detailed information to clinicians on vaccination. on identifying and testing for and treating infections, and that's also available through some of the links in the earlier slides, is providing guidance on risk assessment and public health management of monkeypox cases. We're constantly updating our information on our website, in social media, and in briefings to the media. I think Dr. Walensky is on a briefing as I'm speaking. We're using the same channels to communicate broadly about monkeypox to the public, and as mentioned, CDC is also strongly supporting commercial lab testing and testing at the agency itself. We're developing a series of vaccine effectiveness projects that will help identify data from various locations and populations. We're working closely with community partners, including engaging partners who can help increase awareness in the LGBTQ+ community and to understand what resources are most needed at the community level. We're consulting with public health partners to get their feedback. CDC is also communicating with other countries to share information and understand what's happening globally. We're working with local health departments and the Indian Health Service to understand the epidemiology of the outbreak and to learn about the populations most affected. As I mentioned earlier, community awareness is critical. It's why we do outreach to the public through partners and through media like you. So thank you for your part in helping to ensure that people have updated and accurate information so that they can make informed decisions to protect their health. And I'm really pleased to join your coffee talk today. And I'm going to turn it over to my colleague, Dr. Evans, to walk through our last slide with you.
Thanks, Dr. Damon. Just as we're pulling up this last slide, the focus of this presentation really is to provide clinical information. Let's see. Okay, looks like it's there. And but we did want to share this last slide just to give you some information about an email that went out to tribal leaders and to others. And the email provided information about how tribes can access treatment or vaccine for monkeypox, also known as medical countermeasures. So this slide highlights the information that was shared in that email, and just want to emphasize that we respect tribal sovereignty, and we want to be sure that tribes know that they have the option to receive the medical countermeasures either through the Indian Health Service or through the state. And so that's the main part of this slide. We are planning a call that will be, HHS is planning a call that would have representatives from ASPR, IHS, and CDC. That date has not been selected, but they're hoping for sometime late next week. Thanks.
So we're happy to take any questions that you might have. Again, there's a lot of information and posting on the CDC website. It's a good opportunity for folks just to look around. There's quite a bit of information on clinical consideration, children's adolescents, considerations for prevention and control in non-healthcare settings, including homes, congregate settings, such as dormitories as we're getting into the college years, and college is coming back on and people are coming back on campus. We are working with partner agencies to think about how vaccine use can be expanded as a priority to stop virus transmission, especially as some of the tools that we hope to be able to use in terms of contact assessment have been more challenging in this particular outbreak because a number of individuals report anonymous contacts or contacts with people who cannot be identified for close monitoring and follow-up.
So as more questions are coming in the chat box, first let me go back and say I apologize for the technical difficulties with the PowerPoint. I was moving faster than the speaker. Dr. Damien, you had a question in the chat box about availability of monkeypox vaccines. What is the best way for tribal members in urban Indian health clinics to get access?
Dr. Damon, maybe I should answer that question. Hi. So thanks for asking the question. So again, this is outlined in the email that was sent out today, but you have the option to go through the Indian Health Service or through the state to have access to TPOXX. The Indian Health Service has received allocations of TPOXX as well as the JYNNEOS vaccine, and that you can reach out in the email. It gives the information for the NSSC with IHS and how you can reach out directly to them. And so that's really the best way. And we do have sites that have already received this treatment from them. Thanks.
And Dr. Evans, another question for you is, what is an estimated date of receipt after placing the order with the National Stockpile?
Yeah, thanks for that question, Dr. Johnson. You know, that would be a question directly for Indian Health Service, and it would be better to ask that on the call next week when they're available. We don't have that information at this time.
Just checking to make sure anyone hands are raised. Do we have any additional questions?
So Dr. Evans, I think there's a related question to the vaccine question, and that's access to TPOXX. Is the ordering system the same for that as it is for getting access to vaccine?
Yes, that's correct. So they would go through the Indian Health Service, NSSC, and they have received TPOXX, and so they should coordinate through the IHS to receive that. However, tribes are also welcome to coordinate directly with their state, and the state has received the same email that went out to tribal leaders, just making them aware that tribes do not have to go through IHS. But of course, we do encourage them to go through IHS if possible, because those systems have been set up. Thanks.
Our next question, are people that have received the old smallpop vaccine in the 1970s at risk for getting monkeypox?
So that's a great question. So we are seeing people in this outbreak who've been vaccinated, previously vaccinated as children, do acquire disease. Similarly, we saw that in 2003 in the monkeypox outbreak, where individuals were exposed to infectious excreta from prairie dogs as the likely source of infection. So again, smallpox vaccine, you know, that we got I got as a kid, and then I got revaccinated as a laboratory person, is remarkably long-lived in the protection, but it may not be the vaccination protection that you got when vaccinated as a child, may not prevent infection with this type of exposure, which is really quite a bit of virus, which is being essentially exposed and causing an infection through a mucosal surface. So it's really a high bar for a vaccine to provide protection when you're vaccinated many years ago.
And as a healthcare provider, the next question, and as a healthcare provider, what is the proper PPE for protection?
So that too is posted, and we periodically reevaluate it, you know, on the website. So I can look for the specific link for you that would have the most accurate information. But essentially, we are recommending protection of mucosal surfaces. So contact precautions, as well as wearing respiratory protection. And I believe right now we're at, I would need to look back at the specifics in terms of what the current recommendation is in terms of level of respiratory protection. And largely that is also predicated on the fact that in hospital situation and healthcare situations, there are times when potential of infectious aerosols can be generated.
And Dr. Lopez, I would like to note that Tim has placed the infection prevention and control guidance for monkeypox in healthcare settings in the chat box. If you go to that link, it goes directly to CDC, and in the list of contents, you can click on personal protective equipment, PPE, and it has the information that you asked right there. PPE is currently right now is recommended a gown, gloves, eye protection, and NOSH approved respiratory. Next question, are other countries experiencing monkeypox outbreaks?
So yes, this is really a global outbreak. There are multiple countries in Europe, in Asia being impacted by this, in addition to countries in Africa. So this truly is a global outbreak.
Every time I go out, okay, I thank you all for your questions. Thank you, Dr. Damien, Dr. Evans, for joining us. Thank you for your support and the work that you do. To the over 100 healthcare providers that work in our clinics and in our communities across Indian country, thank you for joining. Thank you.